Hey guys, so for those of you that don't know me, my name is Dina. I am a PTA student from South University. I'm on my first clinical rotation here, and I've been working with Lauren for the past 5, 6 weeks now. I just want to say thank you for listening to my in-service. I know this wasn't the ideal way for me to present, um, but I really appreciate you guys taking time to listen to it. So today I'm going to be talking about conversion disorders. So these are the objectives: discuss the overview, etiology, pathology, signs and symptoms for conversion disorders, discuss the incidence, prevalence, and risk factors, summarize diagnosis and medical management, plan therapy management interventions by incorporating the most recent research, and analyze and discuss a case scenario of a patient who presents with conversion disorder. So what was once considered to be hysteria has been renamed and broken up into two categories: somatoform disorders and dissociative disorders. Somatoform disorders meaning unexplained physical disorders or illnesses, and dissociative disorders meaning the disruption or loss of consciousness, memory, identity, or perception. So conversion disorders fall under the somatoform category, presenting as sensory or motor dysfunctions that cannot be explained by physical disorders or pathophysiological mechanisms. So also conversion disorders have been called functional neurological disorders as well in some of the research I was reading. So the exact cause of conversion disorder is not well understood. Some researchers believe that is most common after physical or psychological stressors or traumatic events. It may be that symptoms of the disorder allow affected individuals to provide a physical outlet to the stress in their lives. However, there are some instances where individuals do not seem to have a stressor that is causing the symptoms. Therefore, in most cases, the exact cause is unknown. I found a meta-analysis done by Bokel, if I'm saying that correctly, of neuroimaging studies on motor conversion disorders, and found through brain imaging that there was a common theme of increased or reduced blood flow to certain areas of the brain, and concluded that this may be the cause of neurological symptoms associated with conversion. It is possible that these changes in blood flow may be caused by the brain receiving information about physical or emotional stressors and therefore avoiding to use certain parts. More specifically, Bokel found a decrease in activity in the thalamus and an increase in activity in the amygdala. The thalamus is the main system to cortical areas where the sensory and motor pathways or signals will pass through. Therefore, it plays a really big role in generating intentional movements and learning adaptive motor actions. Research has also shown increased activation in the amygdala. This is the emotional core of the brain. It's possible that the hyperactivation is related to an emotional response of motor action planning and then inhibits motor execution. So studies have estimated that 20 to 25% of patients in a general hospital setting have symptoms of conversion, and 5% of patients in this setting meet the criteria for the full disorder. Among adults, women diagnosed with conversion disorder outnumber men by a 2-to-1 to 10-to-1 ratio, and less educated people and those of lower socioeconomic status are more likely to develop conversion disorder. Other risk factors include comorbidities and other mental health disorders such as anxiety, phobias, OCD, depression, personality disorders, childhood abuse, and suicidal thoughts or actions. I got this picture from a research article I was reading, and it said that adolescents are also more at risk for conversion. So these are some of the main signs and symptoms of conversion. So some of the sensory and motor Signs and symptoms include impaired coordination, balance, gait pattern, paralysis, localized weakness, loss of voice, difficulty swallowing, urinary retention, altered touch, pain sensation, impaired vision, hearing loss, hallucinations, seizures, convulsions. And then some general signs include a debilitating illness that begins suddenly, a history of psychological problems that improve when symptoms of physical illness appear, and lack of concern that usually appears with a severe physical symptom. So individuals with conversion may also experience issues with other systems depending on the illness they are presenting with. So possible symptoms or affected include cardiac. They may experience shortness of breath, palpitations, chest pain, gastrointestinal. You could see vomiting, abdominal pain, difficulty swallowing, nausea, bloating, diarrhea. Musculoskeletal, pain in the legs, arms, back, joints, neurological, headaches, dizziness, amnesia, vision changes, paralysis, or muscle weakness, urogenital, pain during urination, pain with intercourse, menstrual pains, heavy menstruation, irregular menstruation. But really, all patients can present with, maybe one of these problems or multiple problems. As far as signs and symptoms and these systems that are affected, everybody presents differently. So it really just depends on the patient and what they're going through. Okay. So according to the Diagnostic and Statistical Manual of Mental Disorders, conversion disorder is defined as having at least one symptom of altered voluntary motor or sensory function, the presence of clinical findings supporting incompatibility between symptom and neurological or medical conditions, best seen with a functional MRI. The symptom is not better explained by another medical or mental disorder using CT, MRI, or EEGs to rule out, and it causes clinically significant distress or impairments. So due to problems of case definition and uncertainty, prevalence rates vary largely. This is very commonly misdiagnosed and can expose the patient to unnecessary treatment, testing, increased healthcare costs, and most importantly, more psychological stress. As healthcare providers, we come across the question every day about whether, this patient is really experiencing these symptoms or are they faking it? But according to research and brain imaging, this can be real, and people with conversion symptoms really think that they're incapable of using either their arm or leg, depending on what their signs and symptoms are. They really think that they are sick. It's our job to manage it. The chart on the right just breaks it down on how to diagnose conversion. The second pink box from the top, here, let me slide myself over in case y'all can't see. The second pink box from the top, it looks over some common disorders that are easily confused with conversion disorder, such as a brain tumor, MS, myasthenia gravis, which is a long-term neuromuscular disease that leads to varying degrees of skeletal muscle weakness, polio, stroke, dementia, neuropathies, Guillain-Barré, lupus, and spinal cord injuries. So it's really important to make sure that we're, or not us, but healthcare providers in general are ruling out any of these other disorders that it might look like, but it is very difficult to diagnose. Medical management. So medical management includes psychotherapy. A counselor or a psychologist can help treat conversion symptoms and prevent them from coming back. Helpful with patients that have comorbid psychological conditions such as anxiety, depression. Family therapy is helpful with triggering factors. It helps the patient with problem-solving techniques, reframing of beliefs about their illness. Hypnosis, which I thought was interesting. Neuroimaging supports that conversion symptoms and hypnosis use common neurologic pathways. So some studies show that hypnosis can be a useful adjunct to treatment, but it is not essential for improving symptoms. Pharmacotherapy used to treat underlying conditions. Some studies report reduction in conversion symptoms with the use of selective serotonin reuptake inhibitors, beta blockers, and antidepressants. I thought this one was really interesting. So transcranial magnetic stimulation. Weak electrical currents to alter the brain's biochemistry. There has been success in reducing conversion symptoms related to post-traumatic stress disorder. I thought that was kind of crazy, but thought I'd throw it in there. It was kind of interesting. And then, of course, physical therapy, occupational therapy, and speech therapy. So prognosis. Let me slide over. Symptoms usually last for days to weeks and may suddenly go away. Usually they're not life-threatening, but complications of symptoms or unnecessary medical tests and treatment can be debilitating to someone. For most people, symptoms get better with reassurance and time. 1 in 4 people may show a reoccurrence or new symptom later. Individuals may be more likely to have long-lasting symptoms or develop a new conversion disorder if they delay seeking treatment, if the symptoms come on slowly or don't improve quickly, if they have psychiatric disorders, or if they're experiencing tremors or seizures. Okay, so this is the case scenario that I found. It was done by Deborah Ness. I took it from the Journal of Neurologic Physical Therapy. So there was an 18-year-old woman admitted to the hospital. She fell out of bed, was unable to get up or walk. Her symptoms progressed to include low back pain, episodes of jerking and tingling to her upper extremities, ataxia of her trunk and extremities. The patient had a medical history of a ruptured ovarian cyst and an abortion. Medications that she takes daily include Tylenol. Some social history. She was a senior in high school, planned to attend college in the next 6 months. She had been living away from her parents since she was 15, currently living with her boyfriend. The patient's parents are divorced. She had a history of psychological trauma as her biological father kidnapped her at knife point at the age of 8. The patient was active in sports and other school activities. She lived in a ground level apartment with no steps. So an MRI and CT of the patient's head and spine were negative on admission. The patient demonstrated normal reflexes in upper and lower extremities. Her light touch and proprioception sensation was intact in all extremities, had full active range of motion of all her joints, but she performed the range of motion with large jerky movements. She had normal muscle strength in lower and upper extremities on manual muscle testing. Visible contractions of the knee and hip flexor and extensor muscle groups were noted at rest. These contractions resolved with distraction. She also had normal finger to nose and heel to knee coordination bilaterally. However, she demonstrated high amplitude tremors and jerking of her lower extremities on attempts to stand. The patient's efforts during the physical examination were inconsistent. Her speech, cognition, bowel, bladder function was all normal. So, as far as functional ability, she was independent in bed mobility and was able to sit up unsupported on the edge of the bed, required max assist to transfer to standing. She demonstrated high amplitude movements of her arms, and alternating buckling and hyperextension of her knees when she stood. She did not appear alarmed by these movements and did not lose her balance, even when the movements moved her center of mass out of her base of support. She was unable to ambulate without maximal support of two people. She took large, uncontrolled steps and forcibly extended her torso to swing her legs forward. The patient was only able to ambulate about 5 feet on admission. She was unable to attempt stairs. She was dependent on her mother and her boyfriend for self-care. So as far as the evaluation goes, they said it was conversion disorder, manifested as ataxia. Impairments included uncoordinated movements, poor balance in sitting and standing, functional limitations, difficulty with toileting, bathing, gait, and transfers. Unable to participate in basketball, attend high school, participate in social activities with friends. Her goals were to return living with her boyfriend, return to basketball, attend prom, graduate from high school. So, what do? Research has shown that therapy can be an effective method of treatment for patients with conversion disorder and can help prevent secondary complications such as weakness and muscle contractures as a result of their inactivity. One of the main goals of rehabilitation of the patient is to assist the individual to move away from a sick role and to return to healthy roles in their social, physical, and work life. As we read in the case study, during the initial eval, a thorough history was taken to rule out any other neurological, orthopedic, or cardiovascular conditions. Any stressors in her life were noted, along with psychological distress and history of abuse. Objective measures were taken to validate the patient's beliefs and that she has a condition that is causing her impairments. However, after the initial evaluation, these conversion symptoms should be ignored to prevent reinforcement of the behaviors. During manual muscle testing, true weakness results as giving way of a muscle group, whereas conversion disorder weakness is presented in a series of jerks. So manual muscle tests are not consistent with her functional abilities of what is observed. Once the conversion disorder was confirmed, the therapist started with the development of good rapport with the patient since she's experiencing psychological stress. It's important to be very patient when working with these individuals who are having difficulty adjusting to the stress of illness and disability. Depending on how the patient presents, therapists should treat the impairments just as they would if the patient had a neurological condition. It's been shown that progressing interventions from simple tasks to more challenging ones has been effective in those with neurological disorders, and it's no different with those who are experiencing conversion. The therapist should progress the motor skill and provide less verbal and tactile cueing along with less assistance. Physical activity and exercise are known to benefit in the management of psychological disorders. Aerobic exercise or strength training have both been shown to be effective in moderating psychogenic symptoms. Because of the psychological component of conversion disorder, behavioral modification should be incorporated into the treatment session. A patient with conversion often assumes the role of a sick person, like I had said before. When people recognize their illness, this reinforces their behavior. In a therapy session, when these unwanted behaviors occur, avoid commenting on the impairments and only give positive feedback when the patient performs well with their normal movements, strength, and gait. The therapist should educate family members and other team members, healthcare providers on the behavioral components so that things stay consistent. Some examples of treatment for a patient presenting with paralysis weakness or ataxia, trying to include pre-gait activities such as sit-stands, weight shifting in multiple planes, mini squats, balance activities, eventually working up to gait activities and stair management, dual task activities, adjustment of gait mechanics. Next, it's important to incorporate activities that will help the patient with participation, especially with activities of daily living. She really liked basketball. That probably would have been something good to incorporate, kept her motivated. Bringing in components of the patient's daily activities during treatment will help to expose them to the stressful situations and find ways to manage or cope outside of the clinical setting. So maybe for her, having the mom and the boyfriend present would be a good idea as far as coping. This will help to decrease the likelihood of relapse in the future. This wasn't specifically used with this patient from the case scenario, but I thought it was really interesting and I wanted to add it in as an intervention that studies had used. So electromyography and functional electrical stimulation, or FES, have also been used to allow the patients to see that the affected limb can move and to provide biofeedback to restore their movement. So I just wanted to add that in because I thought that was really interesting. So in conclusion, the outcomes of our patient: after 6 days of treatment, she was discharged and independent in all transfers, gait, and self-care activities. She returned to high school and actively participated in basketball and other extracurricular activities. She pursued ongoing psychological counseling at home. During 3-month phone follow-up, the patient was attending college and doing well. So overall, this one case scenario, she had her specific signs and symptoms that she experienced, but not every patient is the same, like I said before. And I think that it's really a group of people, focusing on what's really wrong with the patient. So whether it be speech, if they're having trouble swallowing or anything like that, occupational therapy, getting them accustomed back to activities of daily living, stuff like that. So I really think it depends on what the patient is presenting with in order to give them the best care that they need. So she just so happened to, I think, need psychological counseling and physical therapy, but for somebody who's having different signs and symptoms, they may need more or less. It really just depends. So with that being said, these are my references, and that was my presentation. If you guys have any questions or want to give me any feedback, that would be great. But thank you guys all for listening into this, and I hope that you enjoyed it. Like I said, if you have any questions, let me know.